Hello friends, welcome to today's YouTube class. I'm Dr. Nasta, a bariatric surgeon from Mumbai. For all those who are online, please give me a thumbs up so that I know I'm loud and clear. I can see your comments on my phone on the YouTube, so I will just wait for people to join in and then I will begin today's class. All those who are online, please give me a thumbs up if I am loud and clear. Okay, Aditya. Yes, Aditya gave a thumbs up. If you can hear me well and you can see my slides, let me know. And then I will begin. Just wait for a few seconds for people to join in. Okay. Aditya says I am clear. Alright. While we wait for people to join in, I'll just tell you a little bit about me. So I am Dr. Amrit Nasta, a pediatric surgeon from Mumbai. I have been at the Unacademy Plus platform for almost 3 months now. Prayosikta is also here. She was there for one of my earlier classes. Hi. So as you guys know, in NEET PG as well as in AIMS PG, they have started giving a lot of focus to image based questions, which is why a lot of my YouTube classes focus on image based questions. Now, there are some ways to get to the answer even if you have never seen the image. Okay, so I am here to help you get to those tips and tricks so that you can solve any image based question by identifying those typical things that speak out. So a lot of people are online now. I hope I am loud and clear, and then I will begin today's class. So today's class is on image based questions on recent topics. Okay, so there are images on hernia surgery and things like that, bariatric surgery. Okay, which are not very much covered in detail in the MCQ books, nor do you have the time to read them from the textbooks. So this will be an MCQ based discussion, and I expect all of you to respond, and then it will be more interesting that way. So let's begin with me, Dr. Amrit Nasta. My referral code is Amrit Nasta, everything in small letters. So let's begin with the first question, first image. Identify this image that you see over here. Is it an ESWL machine, a Mohs micrographic surgery device, a loop for vascular anastomosis, or a robotic console? Alright, let's see what you guys think about it. Aditya, Prayosikta, and all those who are online. Okay, Prayosikta says robotic console. Alright, anybody with a different answer? Nidhi says the same. Malhar Gavandia says the same. Aditya says micrographic surgery device. Okay, someone has given a different answer. Anyone with something else? Anyone for ESWL machine? Okay, Janvi Bajaj also says robotic console. Interesting. Yes, most of you are right. This is a robotic console. You need to know a little bit about robotic surgery. It is fairly untapped in the MCQ world as of now, but you know they are going to ask you things about it. So this is a robotic console. This is where the surgeon sits. Now, how do you identify? First of all, this is the area where the surgeon sees, okay, the image. And the image that he gets is a 3D image. Contrary to conventional laparoscopy, here he gets a 3D image. These two are his hands, where he holds the instruments with his hands. And remember that this console is away from the surgical side. Okay, so the surgeon is not scrubbed up, he's sitting away. Another thing you should see is this. Where have you seen this typical yellow and blue appearance? This yellow and blue colors are typical of a cautery device, right? A cautery device. So obviously this console gives the surgeon the control of cauterizing the tissue with the energy source. As you know, yellow is cutting and blue is coagulation. Right? Yes, Nidhi, that's right. That's cautery. So remember that this is a robotic console. It works on the principle of master slave, wherein the surgeon is the master and the robo is the slave. It's not that the robo is doing the surgery, it is the surgeon only who is controlling everything. Now, little bit about robotic surgeries. Now, this what you see, these are the robotic arms or the robotic instruments. Now, when the surgeon sits on the console, whatever movements he's doing are all going to be manifested on these robotic arms, and this is the patient. So, the advantage is he gets a three-dimensional vision. The instruments have 7 degrees of freedom or 7 degrees of range of movements. Normal laparoscopic instruments only have 2 dimensions, so in, out, up, down, or left, right. In robotic surgery, the instruments have curvatures. So the instruments get 360-degree rotation, which is not seen in laparoscopic surgery. Okay, that is the advantage. And the third thing is the surgeon's tremors are corrected by the robo. So the robo will hamper or dampen the tremors of the surgeon, which is why robotic surgery has these benefits over a laparoscopic surgery. So that was about robotic. Earlier was the console. These are the robotic arms. Please make a note of this image. Now this one. This is something very new. Let's see how many guys know about this. So, which of this is the false statement? Okay, this is a false statement about the suture material below. So, this is the needle, this is the suture. Identify the false statement. So, the statements are no knotting is required, can be used for closing rectus sheath, longer length is required, available in absorbable and non absorbable forms. Please identify this suture. There is something in the suture that is unconventional. This is not your standard suture material. Prayosikta says D, Nidhi says C, Aditya also says D. Okay. What is this suture? It's not your normal suture. Thorn. Okay. Yeah, you are seeing the thorn. That's right. What type of suture is this? Mind you, this has never been asked yet. This is something quite new. It's been there for maybe the last 7-8 years. Okay. Anuj Singh says C, longer length. So two people for C. Chanvi says knotting is not required. Okay. Basically, everybody is choosing one of the options, and like I always say in AIMS, they will always put options close to each other such that all of the options are selected by the students. That kind of a question is a question with a good discriminating index. Like this. Anyone with a different answer, a lot of you are online, you have to know this. It's quite new. This suture material, yes, anybody knows what is the suture material? Okay, the answer to this question is okay. Sunny says A, knotting is not required. Okay, no, most of you are wrong. The answer is C, longer length required. Now, this suture material that you see, it has these thorns which prevents the suture from getting rolled back. So, when I take a bite, the suture can never become loose because of these thorns. The suture can never become loose. So once it goes through the tissue, it's not going to go back. Alright. So this kind of suture, no knotting is required. So knotting is not required is the correct statement. Yes, it can be used for closing the rectus sheath and it is available in absorbable and non-absorbable. Yes, Prayosikta, this suture is called a barbed suture. Absolutely right. This is a barb suture. So what you are saying are the thorns, they are the barbs. Mind you, this is different from a braided suture. I will show you what a braided suture is. This suture, you can see these typical thorns that are coming out. They are the barbs. It's not longer length. Actually, the correct answer is shorter length is required. Obviously, if I don't have to make knots, then the length of the suture lost in the knots is saved. So a shorter length of the suture is required. Now, that was the barbed suture. Conventionally, you have monofilament sutures and braided or polyfilament sutures. This is a braided suture, okay, like a vicryl, polyglycolic acid. So you see how a braided suture is made. Braided is not barbed, okay, they are different. Braided means polyfilament. Alright, braided means polyfilament like vicryl, silk, or catgut. Now, because there is polyfilament, fewer knots are required. So once I knot it, the knot will remain, it will not slip. And these sutures have poor memory. Memory is the ability to maintain its shape. So these sutures have poor memory, and remember, poor memory is useful in sutures. Poor memory is useful. Contrarily, monofilament sutures are like this single line. They have good memory. Good memory is a bad thing in surgery. Alright. However, there are advantages because it's a single thread, there is less bacterial overgrowth. In these braided gaps, the bacteria can remain. So in monofilament, the bacterial overgrowth is less, and they are used in vascular anastomosis like PDS and proline and ethylone. You must have heard of ethylone that you use for skin closure. Alright, so that is about suture material. In AIMS, they love asking about knots and sutures. Alright, so make sure you study them. Okay, this is another new image, never been asked before. Let me see if you can get it. What is this image? Okay, I'll give you a hint. It's of the colon. Is it a barium enema? Is it virtual colonoscopy, optical colonoscopy, or endo ultrasound colonoscopy? Okay, Afreed Jaipuri says virtual. Sunny, Nidhi, Malhar are all saying virtual. Balamurgan, Aditya. Alright. Afreed is one of my final year students appearing for NEET next year. Great to see you. Yes, Aditya, Kennedy, everyone is saying virtual colonoscopy. I am glad you guys know, yes, this is the correct answer. This is a virtual colonoscopy. It looks very much like the normal colonoscopy, but it's not. Can anybody tell me how is this performed? How do you do a virtual colonoscopy? Or what is the more appropriate name of virtual colonoscopy? Yes? What is this virtual colonoscopy? How is this diagram of colon and the inside of the colon coming? Remember, virtual colonoscopy is nothing but CT scan. It's a CT scan of the colon. Alright, so any virtual, like a virtual esophagoscopy, virtual gastroscopy, virtual colonoscopy, is nothing but a CT scan which is reconstructed with the help of a computer. So it is a reconstructed computerized image, alright, of a normal CT scan. So it is nothing but a CT scan. So it's done like a CT scan. There is no anesthesia. Normally, when you do colonoscopy, you have to give some anesthesia or sedation. Here, there is no actual colonoscope going inside the colon. So this is a pain-free imaging. The only thing is, during the CT scan, a tube is passed in the rectum and the rectum is insufflated with CO2 so that the colon gets distended. And when the colon is distended, that is when the CT scan is done to give you an image like this. Alright, so it's nothing but a CT scan. This image that you see over here, this is the conventional colonoscopy, also called as optical colonoscopy. This is how you will normally get the image in a colonoscopy. So you see, this is the polyp you see in normal colonoscopy. This is the polyp you have seen in the same patient in a virtual colonoscopy. Obviously, since it's just a CT scan, you can't take a biopsy. Biopsy is not possible. This image that you see, this is the image of an EUS or an endoscopic ultrasound. Where as the markings are showing, you see the different layers of the wall of the viscous whose endoscopic ultrasound you are doing. And this circle that you see over here, that is the tip of the endoscope. Alright, so that is about virtual colonoscopy. Alright, now this is another new image, something new. What is the technique of the mesh placement in this image? Where is the mesh placed in this image? You can see this is a mesh. Where is it placed? Is it an onlay repair, inlay repair, sublay repair, or an underlay repair? Prayosikta says underlay. Okay. Anyone with a different answer? Where is this mesh placed? In which of these layers? Mind you, hernia very important, very recent, especially laparoscopic hernia. They will ask you something from this. In my earlier YouTube class, also I had said something on hernia. Afreed also says underlay. Okay. Anybody can tell me? Anybody with a different answer? Is it onlay, inlay, sublay, or underlay? Again, something that you must know passing out of MBBS. And an image based question like this, you have to get it right. Okay. Only two people have answered. There are almost 20 of you online. Come on, guys. You have to know this. Where is the mesh placed? What is this? What is this that you see over here? What are these structures? Yes, anybody with a different answer? So this obviously, this is perhaps the omentum. This is the liver. So obviously the mesh has been placed intraperitoneally. This is an intraperitoneal mesh placement as you see over here. So this, the answer, correct answer is underlay. Okay, underlay is the correct answer. The other terminology that they may use is called as an IPOM. Remember this word IPOM. IPOM means intraperitoneal onlay mesh. Here the onlay means on the peritoneum. Okay, it's kind of a misnomer, but it is also loosely termed as IPOM or intraperitoneal onlay mesh. What are these other mesh placements that you need to know? So if this is the skin and this is the defect in the muscle, and if this is the peritoneum and this is the viscous inside, onlay is when I place the mesh over here on top of the defect, on top of the rectus. This is onlay. Inlay is when I place the mesh just inside the defect. This is called as plugging repair, where I have just plugged the defect. Sublay is pre-peritoneal. So this is the peritoneum, this is just above the peritoneum or pre-peritoneal. And the image that you see here is intraperitoneal or underlay, that is underneath the peritoneum. You need to know a little bit about meshes. Normally in an IPOM or an intraperitoneal mesh for ventral hernia, the mesh that is used is a composite mesh. Okay, the mesh that is used is a composite mesh. This has two sides. One side has polypropylene, that is the side that faces above, and one side has PTFE or collagen, that is the side that faces the peritoneum, inside the intraperitoneal cavity. This PTFE or collagen prevents the adhesion of the bowel with the mesh. As you know, mesh is a foreign body, it is inflammatory. So this PTFE side prevents the adhesion of the bowel to the mesh. So because there are two materials, this is called a composite mesh or a dual mesh. Alright, so remember these terms, composite mesh or dual mesh. Meshes are also classified as lightweight or heavyweight depending on their weight, less than 40 grams per square meter or more than 80 grams per square meter. Nowadays, lightweight meshes are preferred. All these numbers you need to know for MCQ. There is another type of mesh called biomesh, which is derived from connective tissue of animals, which is used in infectious setting. So another MCQ right there, biomesh is used in infectious setting. Alright, let's come to this one. This is a little difficult. Try to get this answer. What is this procedure? Okay, it's a recent procedure. Is it Billroth 1, Billroth 2, Roux-en-Y gastric bypass, or mini gastric bypass? Alright, don't jump to the answer on this. This is a little tricky. You will not find this in many books. Yash says C. Kennedy also says C. Roux-en-Y gastric bypass. Okay. Prayosikta says mini gastric. Okay. Anyone for Billroth? Balu Murugan says mini gastric. Doesn't this look like a Billroth? Prayosikta says sleeve. Sleeve gastrectomy and mini gastric bypass are totally different. You can see the stomach is there. It's not a sleeve. Ali Abbas says mini bypass. Nidhi, Aditya are all saying mini bypass. Isn't this looking like a Billroth 2? Why is this not Billroth 2? Yes, Malhar also says D. Don't follow them. Why is this not Billroth 2? This is the stomach. This is the jejunum. This is a gastrojejunostomy. Isn't that what a Billroth 2 is? How is it different? Yes, anyone? Okay, I'll give you the answer. For all those of you who said mini gastric bypass, you are absolutely right. This is a mini gastric bypass. Now, what is a mini gastric bypass? This is one of the surgeries done as a bariatric surgery or surgery for weight loss. Now, let me show you an image of something very similar. Look at Billroth 2. Billroth 2 is nothing but gastrojejunostomy of the loop type, right? So this is the stomach and this is loop gastrojejunostomy. You see the same thing over here. This is the stomach and you see a loop gastrojejunostomy. The only difference is in Billroth 1 you are resecting the antrum. In both the Billroth procedures, Billroth 1 and Billroth 2, you are resecting the antrum because they are done for peptic ulcer. They are done for peptic ulcer. So in both Billroth 1 and Billroth 2, the first thing you do is do an antrectomy. Then in Billroth 1 you do a gastroduodenostomy. In Billroth 2 you do a loop gastrojejunostomy. That is Billroth 1, that is Billroth 2. In this, the stomach is intact. The antrum is not removed. Remember, the antrum is not removed. The stomach is intact and you have done a loop gastrojejunostomy. This is a mini gastric bypass. That is the main difference. Alright, so a loop GJ with intact stomach is mini bypass. With antral resection is Billroth 2. Billroth 1 is gastroduodenostomy. This image that you see is a Roux-en-Y gastric bypass. In a Roux-en-Y gastric bypass, there are two things. First is you have joined one segment of the jejunum to the stomach. So you have a gastrojejunostomy, but remember it's not a loop configuration. Lower down, the jejunum is joined to the jejunum again. That is a jejunostomy. In a Roux-en-Y, you have two anastomosis, a gastrojejunostomy and a jejunojejunostomy. So if you ever see two anastomosis GJ and JJ with a Y configuration like this, as you can see, this is a Roux-en-Y gastric bypass. This is also done as one of the bariatric procedures. Alright, I hope I'm clear with this. Alright, so that was Roux-en-Y gastric bypass and mini gastric bypass. Now another interesting image, never been asked before, and I hope you are able to identify it. Identify this pathology. Is it a pseudocyst of pancreas, a gastric cyst, hydatid cyst, or mesenteric dermoid? And I'll give you a hint. Look at this kept over here. This is the pathology, obviously, the cyst, but what is this? This gives you the clue to the diagnosis. It's something very interesting. So, what is this? What is this pathology? Is it a pseudocyst, cyst of the stomach, hydatid, or mesenteric dermoid? Prayosikta says gastric cyst. Okay. Yash says hydatid. Malhar says hydatid. Satyam says pseudocyst of pancreas. Okay. Kennedy says hydatid cyst. Alright. Everybody giving different answers. Yes, what is this? Don't look at this. Look at this. This gives you the answer. Something interesting. Janvi also says C. Ali Abbas says C. This obviously is the liver. This is Diva's retractor. This is the cyst. Alright. Anybody can tell me what this is? This green colored thing kept over here. This gives you the answer. Even if you couldn't make out this cyst very well, you would get the answer with this. No, this is not pancreas. Pancreas is not green, dear. Liver has not been retracted with this, Janvi. This is retracting the liver. What is this green colored thing? This green colored thing is a colored mop. This is a colored mop, and colored mops are used in hydatid cyst surgery. And the reason is when I am removing the hydatids, the first thing I do is I cover the intestines. Okay, I cover the intestines with mops, and if any of the cyst spill, the colored mops will be able to pick up the cyst. If I use the normal white colored mop, the cyst will get camouflaged. So to prevent camouflage, I used colored mops or mops which are soaked in betadine. So you may get brown colored mops or black colored mops which are soaked. So if there is spillage, the mop will be able to pick it up. So this is hydatid cyst of the liver. Alright, so that's the image. I hope you guys got this. Now a little bit about hydatid cyst. Remember, it is classified on ultrasound. The classification is Garby, where there are 5 grades. There are some signs of hydatid cyst on ultrasound and CT, like water lily sign, floating membrane, or hydatid sand. They can be diagnosed with ELISA. Cassoni test not done anymore. And this is the classical image of a hydatid cyst. In my liver class, I have taken images on CT of hydatid hemangioma, hepatocellular carcinoma, which nowadays they are asking. About this hydatid, the classical thing are the septate. So this black appearance is of fluid, so this is a cyst, and the septate, which is why this is a hydatid of the liver, because of these classical septate. Treatment, you start him on albendazole, and then you can either do a pair procedure, that is puncture, aspiration, irrigation, and reaspiration if the cyst is of an early grade or superficial, or you can do a surgical resection by doing a deroofing or a pericystectomy. The precaution during surgery I already told you. Cover the bowel with mops to prevent spillage. Okay, this is the last one, saving the best for the last. Another new imaging technology. What is this technique? What is this imaging? Is it a HIDA scan, a PTC, indocyanine green gram, or an intra-op cholangiogram? I can tell you a hint. This is the biliary tree. You can see right and left hepatic ducts. What is this imaging? Ali Abbas Satyam say indocyanine green. Janvi says D. Sagar, also my student, says intra-op cholangiogram. Prayosikta, Subulakshmi are all saying intra-op cholangiogram. Okay. Alright, anyone with a different answer? I see some of my students from my MBBS? Is it a HIDA or a PTC? Yes, anybody with a different answer? Anybody going for HIDA or PTC? PTC is percutaneous transhepatic cholangiogram, in case you didn't know. Yes, anybody with a different answer? Very new technique. It's come only in the last 4 or 5 years as a tool in laparoscopic surgery. And a very easy answer. Okay, the answer, some of you got it right, some of you got it wrong. Sagar, you got it wrong. Answer is indocyanine green. It's indocyanine green angiography. So what is this appearance? First of all, even if you didn't know indocyanine green, you could have eliminated the others. So HIDA, you know it looks like a thyroid scan. It's a radionucleotide scan like thyroid scan. So you get those warm, hot and cold appearances. So HIDA will be black liver, then black biliary tree, something like that. PTC is a cholangiogram. It looks like an X-ray. X-ray with contrast. Intraop cholangiogram also is an X-ray. It's an X-ray with contrast. So by elimination you could have gotten the answer of indocyanine green. Now what is this indocyanine green angiography? Indocyanine green is a colored compound which shows fluorescence in certain wavelengths of light. So what is done is, let's say if I'm doing a hepatobiliary surgery, I know that it is excreted by the liver in bile. So what I do is, when I'm doing the surgery, if there is any difficulty in anatomy, I inject indocyanine green into the vein. Okay, it's an angiography. So it goes in the vein, then it goes into the liver, it is excreted in the bile. Then what I do is I change the color of the light of the laparoscope. In a certain wavelength of light, the indocyanine green color is marked and it delineates the anatomy of the biliary tree. So indocyanine green angiography helps me to study the anatomy of the biliary tree or vascularity of anastomosis or in identification of ureters. So this is something new. Indocyanine green angiography used in surgery for delineating certain anatomical structures. Alright, so friends, that was my class for today. I hope you realize the kind of questions they ask and the kind of things you need to know, the tips and tricks in solving image based questions. So I am an educator at Unacademy Plus. Those appearing for May AIMS, November AIMS or NEET PG next year, I will be covering general surgery completely in 4 courses. Like the first course will be general surgery, then the next course will be GI and hepatobiliary. All these numbers that I have written are the number of hours each topic will take. Like liver will take 1 hour. My next course that is going to come is going to be on trauma and recent advances. Some of the questions were from here, robotic surgery. And my last course is going to be super specialty, basically covering everything with one special class on hernia surgery itself. So if you feel like I was useful, like me, there are some 30 educators teaching all the subjects of NEET PG, medicine, surgery, anat, physio, everything. And if it is useful, you can subscribe to the Plus platform where all my classes will be taken, depending on the subscription that you deem suitable. And then you will have access not just to me but all these amazing educators who teach on the platform. All classes will be live, so you can have a one-on-one interaction with me. You can sit at home and attend classes. You don't have to go anywhere, you don't have to travel. The schedule is put up, you just need your Android phone or iPhone and you can visit and attend the classes. If you wish to subscribe, you can use my code Nasta and you can get a 10% discount on subscription of whichever type that you need, and I will be there along with the other educators guiding you through your NEET preparation. Alright, so friends, thank you for joining me. Some of my older students, thank you for coming, and I hope to see you on the Plus platform. At the end of the class, please give a thumbs up and like this video.